Hello, my name is Michael Irizarry, Vice President, Deputy Chief Clinical Officer of the Neurology Business Group at ASI. I'm honored to introduce the Town Hall session this afternoon that will be focusing on the importance of early intervention and prevention of Alzheimer's disease. For over 30 years, ASI has been committed to addressing one of society's greatest unmet needs, Alzheimer's disease and other related dementias. Our human healthcare mission is a driving force behind our efforts. ASI aims to understand the true needs of patients and families dealing with dementia, not only to develop precision and breakthrough medicines, but also to advance care by providing educational and practical solutions for managing the disease. In order to prevent and treat dementia, we will need to find innovative ways for earlier identification of cognitive decline and diagnosis. We'll need to address the stigma that may prevent people from seeking diagnosis and treatment. We'll need to increase public and physician awareness and understanding of the disease. And finally, also to reinforce the importance of lifestyle and health modifications. Organizations like Us Against Alzheimer's, who can bring together top experts in the field, are critical to the advances against Alzheimer's disease. I look forward to the discussion today, and on behalf of ASI team members in the US and around the world, we are grateful for your dedication and look forward to helping conquer Alzheimer's and related dementias together.
Imagine a time when people no longer believe that Alzheimer's and other dementias are unavoidable and unstoppable. That cognitive decline is not seen as an inevitable part of aging. Imagine the possibilities, the benefits, the hope, when people of all ages understand that there are steps that we can take to promote brain health, to reduce the risk of Alzheimer's and dementia, to delay onset and even to perhaps prevent this dreaded disease, to increase the likelihood that more people can thrive and remain independent into their later years. More and more, research is showing that Alzheimer's and dementia can be delayed or prevented. Studies indicate that up to 40% of dementia cases are potentially preventable. How? By addressing things such as hypertension, physical inactivity, smoking, depression, diabetes, obesity, brain injury, air pollution, excessive alcohol consumption, education, hearing impairment, and social isolation. Our nation must do more to turn this promising news into reality. The United States should set an ambitious national goal to prevent Alzheimer's disease and related dementias. We need to launch the Alzheimer's version of the Million Hearts campaign to reduce cardiac deaths. Momentum is building for a national dementia prevention goal. More than 150 organizations and experts already have joined together to call for adoption of a national dementia prevention goal that aims to reduce prevalence by 2030. AARP, the American Heart Association, American College of Preventive Medicine, Concussion Legacy Foundation, Milken Institute, National Association of Chronic Disease Directors, National Kidney Foundation, National Consumers League, Unidos US, Volunteers of America, YMCA. These are just a few of those calling for action on this national prevention goal, and more are joining this effort every week. But that's not enough. It will take a new national commitment, new partners, new approaches, and new attitudes to get in front of this disease and to get a national prevention goal adopted. It's time to expand this movement. It's time for Congress and the administration to get on board and adopt a national prevention goal. It is time to replace despair and disappointment about Alzheimer's and dementia with determination and hope. How do we build a multi-sector movement to reduce the prevalence of dementia by 30% or more by 2030?
Hello, everyone. Welcome to our town hall on building a movement across the lifespan to prevent dementia. I'm Sarah Smith. I'm the editor of Prevention Magazine, which is a 70-year-old health brand committed to the science of a better life. If you're here today, you probably agree that brain health is paramount to a long, full life. But how do we get it the attention it deserves at every level? As you heard in the video, Us Against Alzheimer's is calling on our nation's leaders to set an ambitious but reachable goal to reduce the prevalence of dementia by 30% or more by 2030. But we have to work together to get there. So I am joined by some of the leading minds in this area so that we can build this movement today. I have with me today GILL Livingston, who is a professor of psychiatry of older people at University College London, who also led the Lancet International Commission on Dementia Prevention, Intervention, and Care. And we'll be talking about their most recent report published this past summer shortly, and it is fascinating. Chris Nowinski is the founding CEO of the Concussion Legacy Foundation and a co-founder of the Boston University CTE Center. He's an all-Ivy Harvard football player turned pro wrestler turned neuroscientist. So we are grateful for all of that experience and insight today. Eduardo Sanchez is the Chief Medical Officer for Prevention at the American Heart Association and the AHA lead on initiatives with the American Medical Association and the American Diabetes Association. His much lauded experience in public health is a huge benefit to our conversation. Charlotte Ye is the Chief Medical Officer for AARP Services, where she works on programs that help lead to enhanced care for older adults. She's spent more than 3 decades as a practitioner of emergency medicine and has been an administrator for Medicare and Medicaid, so we are fortunate to have her expertise on this panel too. So I'm sure you are all eager to hear what they have to say, so let's get started. I want us to first talk about what we know now about brain health and prevention and the potential to reduce the risk and the prevalence of dementia. So Dr. Livingston, can you start us off by talking more about what we know to date about prevention and that latest Lancet report findings, particularly the 3 new risk factors that have been identified?
Okay, thank you for asking. The headline of our report is on prevention is around 40% of dementias, just from knowing about the 12 risk factors that we've included, are potentially preventable. If we had medication that would do that, we'd all take it. We'd throw money at it. So, we identified in 2017, or we calculated in 2017 about 9 risk factors. And we took a life course approach. So I think the important thing to understand is that risk or prevention of risk starts really early in childhood with education. Then what happens in midlife makes a real difference, and in late life it continues to make a difference. So we calculated about 9, but more recently we added 3 more risk factors, as you say, which have new information and new evidence. So let me start off by saying, just before I talk about the 3 ones, these 3 ones, that 3 other risk factors account for half of the possible prevention, and that is in early life, less education, in midlife, peripheral hearing loss, and in late life, smoking. And you add them up together, they account for 20% of preventable risk, 20% of population attributable fraction of dementia, which may be prevented. The 3 new risks discussed and talked about are traumatic brain injury, excessive alcohol, and pollution, air pollution. So let me start off by talking about alcohol. I don't think it's going to be surprising to anyone that very large quantities of alcohol impact on your brain, but what we found in our new meta-analysis is that drinking what might be regarded as socially quite acceptable amount, so 14 drinks a week, increases your risk of having dementia when compared to drinking less alcohol. And that's really important. I think that people might think if they have a drink with dinner every night, a couple of glasses of wine, then that's no risk, but that's not the case. Moving on to traumatic brain injury, we're talking about traumatic brain injury in midlife, and that's from road traffic accidents, military incidents, recreational sport, firearms and falls. And we've always known that if you have a major brain injury, then at that point you might lose your ability, your cognition. But I think that what we haven't realised is that even if you recover, your risk is higher than it would have been, and it remains higher over the next 30 years. And the worse the injuries and the more injuries you have, the higher the risks are. And finally, air pollution. There's not a great deal that any of us can do about individual air pollution, but whatever it is in the air, different sorts of particles, whether it's particles from exhausts or particles from anything else, increases the chance of dementia. And that's something that governments can make a difference. I can and probably will later say a lot more about it, but I know you want to move on.
Good, I hope you will, thank you. I would love if everyone else could weigh in on factors that affect dementia too. Dr. Sanchez, would you jump in and talk about the heart?
Sure, happy to. I'll talk about the risk factors, because when we talk about heart disease and stroke, and we talk about risk factors, there are some common threads, common root causes. Among them are diabetes, high blood pressure, being overweight or obese, being sedentary, smoking, and having high blood pressure. Don't think I mentioned it. 6 of those are among the 12 that Jill just mentioned. They were easier for me to rattle off than they might have been, because those 6 constitute what we consider the 7 factors that define cardiovascular health and brain health. And you'll see the overlap: not smoking, healthy eating, physical activity, healthy weight, healthy blood pressure, healthy blood glucose, healthy blood cholesterol. We didn't talk about, but healthy eating, physical activity, and not smoking are 3 factors that one can control oneself to some degree, not totally, and they contribute to the other things, including dementia. So we believe living a good, healthy life for cardiovascular health is going to protect your heart, protect your brain, not only from stroke, but from dementia.
That's great. Thank you for explaining that connection to us, how those things go hand in hand. Dr. Nowinski, can you talk a little bit more about TBI, your area, or other things you want to bring up in addition to Dr. Livingston?
Thank you. Thank you for the opportunity. I was thrilled to see traumatic brain injury added to that wonderful review paper in Lancet, because it's something that I've lived but was never really aware of while I was getting those brain injuries. And I think I own the record for most brain injuries on this panel. I've had probably about 15 diagnosed concussions over the years.
Wow.
But what's interesting is what's not in that paper, because we don't yet have enough data, but it's coming very quickly, is this idea of, as Dr. Livingston pointed out, we've studied midlife traumatic brain injury very well. And you don't want to get that. And a lot of that is accidental or falls or accidents. But there's this other world that's a little more of an ethical discussion, which is exposure to repetitive head impacts in youth. We haven't been studying it, so we don't exactly know the numbers. But you can think of it as there's the single TBI group, and then there's this club that I'm in, and a certain percentage of the population, we call it the 10,000 hit club. This is American football players, soccer players, rugby players, ice hockey players, Australian rules football, boxing, MMA, certain military exposures, breachers, people who deal with explosives, and victims of domestic violence, right? We're a special club that we've only really started studying. And I'm thrilled that we're talking about preventing dementia, because most of this outside of military and abuse is voluntary exposure to these 10,000 hits, plus the brain injuries that come with that. And a little window into that data, we can study groups like NFL players, because we know the denominator. And we know that NFL players have a relative risk of dementia based on some earlier work of about 4 times greater risk of dementia and of things like ALS and different neurodegenerative diseases. And then our team at the Boston University CT Center, we're looking at chronic traumatic encephalopathy primarily. And we don't know absolute risks, but we did learn relative risk in studying 266 deceased football players, and finding that each year of football they played appeared to increase their odds of developing CT by 30%. And the end of CT is dementia. And then we've also published that athletes who played more than 8 seasons of contact sports had 6 times the rate of Lewy body disease. So this is a sort of a new area of focus, but it's a tremendous opportunity for prevention because we're talking about mostly children getting exposed, and we're talking about it being entirely voluntary.
That's a really fascinating point about voluntary and the choices that we can make. Dr. Ye, can you weigh in now on factors that affect dementia?
Certainly, and I just want to say thank you to the Lancet Commission on Dementia, because in addition to the items that you described and Dr. Sanchez and Chris described, we have, I love the fact that the Lancet Commission has identified hearing impairment. It is the epidemic of silence, is how I like to say it. 2/3 of people 70 and older have clinically significant hearing impairment, and yet only 20 to 30% ever get hearing aids. And yet think of the risk of dementia. We did a study with Johns Hopkins and with the University of California and Optum Lab, starting with over 100,000 large-scale observational study, and we found an association of a 52% higher risk of dementia if you went 10 years without correcting your hearing loss. This really matters. And by the way, it also costs us money. It was over $22,434 per person for uncorrected hearing loss over 10 years. So it matters. And yet, surprisingly, there is such huge stigma against hearing loss that no one gets their hearing tested, and only 20 to 30% of people with hearing loss ever even get a hearing aid. We had an ARP study that actually showed more people admitted to having colonoscopies than they did to getting their hearing test. So this is a huge factor. It is the single biggest factor of avoidable dementia in the Lancet Commission. So why wouldn't we want to address this?
That is fascinating, Dr. Ye. I'd like to stick with you for a moment because I think that goes hand in hand with a question I want to ask you about how I think a lot of people see dementia, and I think probably hearing loss too, as an inevitable part of aging. But I think you don't agree with that. And I would like to hear about that and how we can change that perception.
Yeah, so I think it's fascinating that when we survey older adults, over 90% say, dementia is a really, really serious problem in the US. And yet 3/4 think that cognitive decline, memory loss, et cetera, is just a normal function of aging. And if you think it's normal, you're not going to do anything about it. Similarly with hearing loss. And yet this can be addressed. If you do have hearing loss, getting your hearing tested, getting a hearing aid, there is evidence that if you get a hearing aid and you do speech comprehension and rehabilitation, you can actually reduce your risk of dementia. But what's really scary to me is not just older adults, but the younger generation. We also surveyed about noise, and we know that loud noises and exposure to noise can actually increase your risk of hearing loss. In fact, that's probably one of the silver linings of the COVID pandemic is we don't have the big stadiums and the noisy bars that you're exposed to anymore. But what is fascinating to me is 31% of millennials are already saying they have difficulty hearing in noisy spaces, and 38% of Gen Ys. So if we are not careful in addressing both the prevention of noise and as well as early hearing test and early correction, we might see an even greater epidemic of dementia to come. So I like to say, you think you're old with a hearing aid, you are old without one.
That'll stick with us. That's good. Another big issue I want to be sure we address at the top here is, Dr. Sanchez, I hope that, since you're on the National Quality Forum Disparities Committee, can you give us an overview of the health inequities in this area and why we should be keeping that in mind throughout our conversation?
Wow, that's a really important issue. At this time, COVID, some of the issues going on with social and criminal justice system injustice have brought to light disproportionality. So there is disproportionality of dementia by race, ethnicity. Some of that is predictable based on some of the risk factors that we just talked about, because there is disproportionality of those risk factors across the population. So African Americans are likely to experience more dementia than whites. And again, when we look at risk factors, the risk factor profile will predict that. Education, when we look at education levels, there's a disparity. When we look at blood pressure, type 2 diabetes, obesity, there are disparities there. When we look at exposure to air pollution, there's disparities there. Low income, people of color, more likely to live in places that not only have air pollution, but to Charlotte's point, have noise pollution, because you can move away from those loud factories or loud buses or whatever it may be. So what I would say to you is that if we can address those risk factors, one, if we can have as a principle that drives what we do, health equity, two, and if we can admit to ourselves that social determinants of health and structural inequities have to be addressed in order to equitably reduce the likelihood of dementia, we can get to that place. And I see Chris on the screen. I don't know if there are disparities around traumatic brain injury, but if we looked hard enough and deep enough, I would bet that there are, and the kind of sports that some engage in versus others also creates a disparity of risk. And so there's disparity of risk that concentrates in some versus others. Thank you for the question. Really, really important. It's an issue of the day that has profound implications in so many other realms, even besides dementia. And I think the reminder is if we did all the things that we could do to prevent dementia, the collateral benefit, heart disease that goes down, traumatic brain injury that goes down, strokes that go down, and oh, by the way, suicide that goes down. I will share one more thing before I go. I was looking at the top 10 causes of death in the United States. So Alzheimer's is number 6, 122,000 or so in 2018. Stroke, another brain illness, is number 5, about 148,000. And suicide, which I would put into the category of a brain disease, about 48,000. You put all of that together, it's 300,000 deaths. That would push that collective to be the number 3 cause of death in the United States of America. Not insignificant.
No, not at all. Great point. Thank you. You know, when you talk about addressing these risk factors and these disparities in care, you know, let's talk about getting messages to people. Dr. Nowinski, let's start with you. Can you speak to the timing of addressing these factors? You know, you touched on it earlier when you were talking about youth, because I mean, you were a football player and a professional wrestler, and you know, this was an interest you came to later. So when would have been the time for you or your family to have been thinking about this?
That's a great question, and I appreciate the opportunity to share my experience, because I suppose I'm a case study for doing a terrible job of preventing dementia risk factors. And my issue is that, like, my course really started when I was a child, right? So when I was 13, I had no risk factors, for nothing on that list. And then I decided, you know, I was sort of recruited and encouraged to play football because I was tall. And so I was 6'4" and 155 pounds. So I was a super skinny kid. And the football itself opened up the door to those 10,000 head impacts and all those brain injuries that we know are increasing my risk for certain types of brain diseases, including CTE. I also didn't appreciate, though, that by becoming a lineman, just because I happened to be like one of the biggest guys in the team, they said, okay, you're an offensive lineman now in high school. And that meant they started encouraging me to gain weight. And so I started gaining weight pretty prolifically. So I went as a 13-year-old, 6'4", 155. 8 years later, as a senior in college, I'm the same height and I'm 308 pounds. I doubled in size.
Wow.
And it never dawned on me when I was a freshman in college and I first got diagnosed with high blood pressure, what that might mean for me long term. Nobody brought up, hey, by the way, high blood pressure is really bad for you and could increase risk of dementia and all sorts of other things. And so now I'm clinically obese. I've got high blood pressure. and I've got all these injuries, and it all happened to me basically between 13 and 22, right? And so now I'm 42 and I've got 2 young kids, and I'm like, oh my God, I've really got to scramble to lower my risk factors. I've done so much damage all in the past, and a lot of it is a minor. And so I'm in the midst of a weight loss contest right now. I'm trying to get under 270, but like, you know, the part of the problem is it's hard to lose the weight once you put it on. I'm still being medicated for high blood pressure. And so I guess one of the things that comes from this is just the idea that we need to start talking about this earlier. It's never too early to start talking about dementia prevention. And you know, the literature is now, you know, I mean, the graphs in the Lancet paper, if you haven't seen them, are wonderful, sort of displaying like, hey, you have chances to intervene. And you know, and for me, it's interesting to think that it only comes up in our neuroscience meetings and the BUCT Center, we talk about this, but in regular life, people aren't talking about this enough. And that's why I'm so supportive of this campaign, because there are so many opportunities that we don't talk about. And it really is across the lifespan, and recognizing we have chances all the way through to reduce our risk. And we really need to start taking advantage of them.
Thank you so much for that, you know, personal experience story. And I also just think it's so interesting that, you know, you are so educated in this area, and yet it's still, you know, something that you have to work hard on, right? So, Dr. Livingston, what else would you add to our understanding of brain health across the lifespan?
Well, I agree with everything that people have been saying, but I wanted to emphasize the sort of hopefulness of some of the situations. So, in randomized controlled trials of reducing blood pressure using antihypertensives, and they had to stop the trial. It's called the SPRINT trial, and many people may know it. They had to stop the trial because keeping people's blood pressure at less than 120, the systolic, was so much better than keeping it less than 140 that they couldn't go on. However, following up the people 5 years later in the SPRINT Mind trial, and they didn't know what happened in between, they were still they were less likely to develop cognitive impairment and less likely to develop dementia. So treating high blood pressure can make a difference. If you've got it, it's not necessarily a sentence. It's keeping it down with whatever means you want. Exercise, weight loss, and medication can really make a difference. Equally, studies have shown that even in late life, if people stop smoking, their risk goes down. And as Charlotte's been saying, that while there's probably I would say is a higher increased risk than she thinks, a twice risk of having dementia if you have hearing loss. There is no increased risk if people use hearing aids. So there's a lot of things that you can do that can really make a difference. So on the one hand, you can not know about it and ignore it and be at high risk. And another, you can know about it and really begin to make things that reduce your own individual risk. And society can do things that reduce risk as well. It's like Eduardo said, some of it's personal, but some of it's in society. If you're living in a place where the only food you can get within walking distance and you don't really have money for transport is really high calorie, there's not many pavements, there's not places to exercise, and you're pretty likely to be overweight and quite likely to have high blood pressure and quite likely to have diabetes. So it's a societal input because people who come from deprived neighborhoods or from minority ethnic groups have the most to benefit and need it the most, making these changes. And it really would make a difference to the people. Many fewer people develop dementia, and that makes a difference to them, but also to their families and to society. Very expensive to look after people with dementia.
Right, good point. Yeah, thanks for pointing out that, you know, there's a hopefulness here and that we have answers. But Dr. Sanchez, how do you think we can share this information and these brain health messages in a way that people will remember and be encouraged to follow?
Well, one is to have messages that resonate. So one way is to engage those that we're trying to send the messages to and say, and ask them in focus groups, et cetera, what would resonate. I ran the state's health department in Texas. We were trying to figure out how do we deliver messages to young people. What they told us is don't have the older folks be the ones who are delivering the messages. And they helped us customize some messaging for young people. That's one. But I also think, I'm just going to repeat what Jill said, we need to, one, message, and then we need to work to create the conditions where the things we're saying to people they can and should do are really easy to do. And so creating noise-free environments, creating air pollution policies that protect air, making sure, I hope Chris would agree that we try to figure out how we minimize, if not eliminate, head contact that takes place. And then the message is coupled with the situations, the circumstances, the conditions that make that messaging possible. I do think that one frustration is that sometimes we message and the ability of a person to be able to do that which we're telling them to do is either not possible because of the situation they're in, or because they don't have the resources to take care of things. So I'll add one more for Charlotte's list, and that would be that hearing aids become a durable medical equipment that people can get with their health insurance, and that is not always the case.
Well, I actually want to add one hopeful thing is there is over-the-counter hearing aid legislation for mild hearing loss that has been passed. So we expect the regulations to be coming out soon. And while as initially, and we know with Medicare will not cover hearing aids because statutorily it's not covered, because in 1965 we thought that hearing loss was a normal consequence of aging, so we would never treat for hearing loss, which we now know not to be true. But about half of insurance actually covers some form of aid towards covering for hearing aids. And if you're part of the VA system, that is actually the most common disability reported by veterans for which they can get coverage for hearing aids. So that can be done. And I just want to tap into Jill's comment about hopefulness and positivity. We didn't talk about another factor that is associated with increased dementia, which is social connection. We have a study from AARP that says the more friends you have, the more healthy behaviors you engage in. Healthy exercise, eating, nutrition, social engagement, etc. So I do think as a society, we should be thinking about how do we stay connected. It is difficult in these COVID times, but look at the Zoom conferences. Look at our ability to reach out. We clap for people across balconies. If we can keep that kind of social connection, that may be another area that we can reduce. And if you have friends around you to support you, you're more likely to engage in the kinds of healthy behaviors that we talked about.
Can I say something about that?
Please do.
Yeah. So I think that we've done some studies looking at social connectivity, and we find that it's protective, and part of that is accounted for by the fact that people have more healthy, that people live in a more healthy way, but part of it is not. And I think that seeing other people is socially stimulating, is cognitively stimulating, and helps your brain in and of itself. So it's more than one route to it, and it also decreases depression. And equally, not having hearing aids means you can't hear other people, and you tend not to go out. So I think that there's a really important message that doing things that are enjoyable, like going out, talking to people. I know there's a limit, as you say, with COVID, but doing these things really make a difference. And the second thing I want to say about hearing aids, so I'm from the UK where we have socialised medicine and hearing aids are free. We still have a problem with people wearing hearing aids because they're greatly stigmatised. And when I was growing up, it was there was a stigma to wearing glasses, but there isn't anymore. And I think that that's something that could really make a difference. Is thinking about campaigns about the stigma of hearing aids. They're now making them prettier. Just thinking about how it can be, because a lot of people feel, like Charlotte said, that wearing a hearing aid means you look incapable, old, decrepit, not the sort of person you'd want to be. That's something we need to change, because people won't wear them they think it says that they're a useless sort of person.
Yeah, and I think there are several things. One is it's associated with being old. We've done focus groups and people say, I know I've got hearing loss, but as soon as I get a hearing aid, I'm no longer older, I'm old. And as I said before, you will be old if you don't wear a hearing aid. But it's also, I love your idea on fashion. Nowadays, everybody wears things in their ears. So why can't we just show off hearing aids? And the third is people don't realize that hearing aid technology is way past your grandmother's technology. There's a company out there now, Starkey, that makes a hearing aid that can translate 27 languages in real time. So imagine, that you will want a hearing aid just so that you can talk to other people in other languages. Think of the brain stimulation, the social connection, let alone that you're treating one of the treatable causes or avoidable causes for dementia, which is hearing aid.
I think it's a fantastic idea to market it like earphones, like things, and just to begin to think about it like that. And also hearing aids now have Bluetooth, so you don't even need to put on your earphones to listen to what's going on and to take phone calls. So I think we need a marketing and a change. And like Charlotte said, it's the biggest risk factor. It really could. So what's good for your heart is good for your brain. But what's good for your mind, what's cognitively stimulates, it's also very good for it.
Right. I mean, just to give you a personal story, my father had age-related hearing loss, and for 10 years, he absolutely refused to get a hearing aid or even get his hearing tested. And over the years, we thought actually, and I'm a physician, we thought he was getting dementia. He was sitting by himself. He wasn't talking to people. He was stumbling and walking. Finally, when my mother was locked out of the house for half an hour because he didn't hear the doorbell ring, he finally admitted and got a hearing aid. 2 months later, we see him at a family reunion. He is regaling people with stories. He is telling jokes. He gets out of his chair. He walks with confidence and stride. And I went, oh my God, I thought it was cognitive decline. I thought it was dementia. And all it was is he couldn't hear. So this is really powerful for social connection, for allowing physical activity, for allowing you to be part of society, challenging your brain and keeping it active. And it is just so simple to get a hearing test.
I'd love to use that as a jumping off point, Dr. Ye, to talking about how I think just 16% of people get regular brain health assessments, which Medicare covers free of charge. Meanwhile, the cumulative impact of managing dementia consequences is estimated to be over $1 trillion by 2050. So we have some number disparity here that seems bridgeable. So what do you think are things that can be done at the doctor or medical community level to improve the number of people who are getting assessments?
So I think the first and biggest step, and this is why I love the Lancet Commission and why I love this campaign, is for people to understand there are things you can do. Most adults think you can't do anything about dementia or cognitive decline, so why would you do anything? So first and foremost, you can do something. And if you raise it early, you can start with these protective effects of managing your diet, managing your obesity, managing blood pressure, managing trauma. So I think that first piece of awareness that it is not inevitable in cognitive decline, not just among the general public, but frankly among the physician and the medical community as well. So much of physicians think, oh, there's nothing we can do, but it's not true. Getting rid of that fear and stigma that there are options available would be important. And we all have a collective duty if we want to keep the cost of healthcare, the cost of community and social resources, reduce the stress on caregivers. We have a collective duty to actually identify early and start implementing those protective effects. So this campaign is first, let's change that perception of aging. It is not about decline. And wouldn't you want to preserve that wisdom that you get with aging?
And when we're thinking about changing the way people think or changing systems, I want to jump to you, Dr. Nowinski, to hear about what kind of systems changes you see, maybe in the area of sports probably, and how it fits into, you know, our culture's love of sports. You know, it seems like a tricky one to change.
Yeah, as you've identified, I'm focused on one issue. And it is an interesting sort of systemic change we need to create in sports. You know, sports are great. They promote exercise, which we want everybody to do, with this being one of the reasons. Promote socialization, all these good things for the brain. But some of those sports bring with them extraordinary brain trauma. And we accept that brain trauma for sort of the wrong reasons. You know, was an undergrad, as an undergraduate, I studied sociology, and sort of I now appreciate that the sports that kids play, they play primarily because those sports were invented for adults, right? Whether it's football or rugby, or they were college athletes and then pro athletes, and then it worked its way down. And so now we have children playing by the rules that the adults play. We all accept these brain injuries. We all accept the NFL players getting knocked out every weekend because we assume there's informed consent. And we assume that they accepted that risk, they're getting compensated for that risk, and so that's okay. But we don't think enough about the fact that, well, if there's 2,000 NFL players doing this, there's also 3 million children doing this without informed consent, without compensation. And changing that system is very difficult because the kids want to play the sports that their heroes play, right? And by the same rules, they want to wear that helmet, they want to look like them. The pro sports don't want to change that because they're all fighting each other for lifelong fans. And the data is very clear, whatever you play as a child, you'll be a fan of later on. And then this shift hasn't happened because we haven't really had the evidence and this spotlight on concussions and CTE that we have today. And so now we're trying to make these changes sort of sport by sport because every sport runs its own show. And so in the US now, we're able to leverage the first CT cases in soccer players to convince US Soccer to ban heading for children before 11. So we're no longer taking the 2-3 pound projectile and throwing it at a child's forehead. And when they duck, you go, no, don't duck, hit it back with your brain. You know, we don't do that anymore because we now know it's a bad idea. That is slowly, that conversation is now happening in the UK and it's going to spread worldwide. And that's partially because soccer rules are sort of top down. Football, we're having a real heck of a time trying to change people's habits, partially because there is no governing body to talk to. And the one governing body that is there is really funded entirely by the NFL. And again, that's about recruiting your kids. And so last year, we developed a campaign to start to change hearts and minds by drawing the analogy that, you know, we identified that your risk of CT goes up 30% per year, and that gives you this incredible curve. And it's actually about the almost exact same amount as your odds of developing lung cancer go up each year you smoke. And so we filmed a PSA with kids smoking cigarettes on the sideline, lit by their parents while they played a football game. It got a lot of attention, won a lot of awards, but we had to get people to think about it differently. And we're really just asking them and fighting this business and fighting entrenched interests and fighting the fact that you can't see brain injury while it happens is hard. And so, you know, to give you a window into it of how strong this relationship is, if we took 3 years off of every football player's career, you know, and on the front end, they started 11 instead of 8, we would cut CT rates, we anticipate, by more than half. So it's, that's what 30% per year compounding does. So we do need to change things, and we need help from the public health community and this messaging of the simple thing is, don't hit your kid in the head, and don't let anybody else hit your kid in the head. You know, around the office, we call it the Don't Hit Kids campaign. And like any parents out there choosing sports for your child, pick the ones where they don't hit your child in the head.
It sounds very simple when you put it that way. Thank you.
Yeah.
Dr. Sanchez, would you actually jump in and talk about what role education plays at the societal level?
Oh, yes. I'd love to. So education is one of those social determinants of health that many of us talk about. We haven't quite figured out what to do about. But when we look at the distribution, for example, of graduation rates by race ethnicity, we have a huge divide in this country where Latino, Hispanic children, African American, Black children, American Indian, Alaska Native children, much lower graduation rates in general as a group than whites and Asians. Low graduation rates also are correlate with income levels. But we've got a lot of work to do in this country because as you've seen, and I think we heard, education may be one of the more important variables because it leads to some of the other risk factors. So low educational attainment, a higher likelihood of drinking immoderately, higher likelihood of a sedentary lifestyle, higher likelihood of being a smoker, and so on and so forth. So as we think about this comprehensively, getting our head around what to do is critically important. And there are things that can be done. So there is an evidence base for what should be done. One, universal pre-K, huge difference maker. In the United States, if you've got universal pre-K, the likelihood of getting to third grade at or better than reading level is very high, and getting to that place at third grade is a predictor of graduating from high school. There's other evidence-based programs that even at a high school level, when you intervene with underperforming children, you can get them graduated out of high school and into college. And something I remember from my years as a state health officer, the demarcation for the difference in mortality rates among the population is 1 year of education or more after high school. So if you can get a child graduated from high school in 1 year of education, doesn't have to be towards a college degree, it can be vocational training, it could be any number of things. That seems to be the demarcation. And what I'm hearing is that would have a tremendous impact on the downstream likelihood of not having dementia. So critically important. There's some evidence-based things we can do. There's some policy change things we've got to grapple with in the United States. But I'm going to go back to hope is running high because we know what can be done. We just have to get it done.
Yes. You know, I love that we're talking about dementia prevention when we've talked about pre-K, 8 to 11-year-olds, college. I mean, it is a hopeful thing that we can talk about the lifespan and how much we do know with kids that we can protect. And so actually, you know, I'd like to talk about the future, you know, what we're doing for these kids and for adults and for everyone. Especially since Alzheimer's and related dementias are expected to nearly double over the next 20 years without you know, this kind of movement that we're creating. So Dr. Livingston, can you talk about what your ideal world would look like when it comes to brain health?
Well, that's quite a big question, isn't it? I mean, I think really we've got a consensus here that there needs to be a lot more understanding, and it needs to be a sort of professional advertising understanding. We need to know how to communicate with people so that they understand that they're damaging their children's brains, or they understand that hearing aids are that hearing aids are smart, not a sign of being old. So we need to have huge amounts of professional communication so that people understand what they can do and the hope in the future. So I think that's my first thing. And then I want interventions like at societal level, the understanding that there has actually been a reduction in the incidence of dementia in America over the last 20 years, 12.5% a decade. So while there's a lot more people, because with dementia, there's a lot more older people, the number per 100,000 older people has reduced by 25% in 20 years. And that's because of things like reduction in smoking and more education and treating heart disease. So I think you understand that we know it works and we can do more. And the thing that people most want to avoid in old age is getting dementia. We know how to, not guarantee you can't do it, but to dramatically decrease your risk. So to make society to give people the education to make the choices, to make society that people are not driving into head injuries, either from road traffic accidents or from sport, that they can avoid, to get high blood pressure treated when you're young, and to have hearing aids available and stopping smoking available. In the States, I'd like that to be available free for everyone, because it would save a huge amount of money for everyone, and there would be many fewer people living with dementia and many more people living healthy older age lives and contributing to society.
That sounds like a great future. Does anyone else have a thought on, that sort of ideal world, what it would look like, and how, well, I'll get to the next question in a sec, but if anyone else would like to jump in.
So I wanted to build on Dr. Sanchez, saying there are things we already know about. So I don't think we have to only think about ideal. So one example that we could combine a couple of these ideas is ARP did a study and has experience with the Experience Corps, where you took older adults working with third graders to teach them to read. It was a volunteer program. In fact, it is still going on. And what happens with these third graders, they're more likely to finish school, they're more likely to go on to college, they're more likely to graduate, they're more likely to have a career, they're more likely to have better income. So imagine if what we did is do something that is truly multi-generational, where we tap into the value of older adults, create that positive perception of aging, that we can have them work with children to make sure they're doing activities that don't require being hit on the head, that we can help work with them on reading. And if you can't hear a child talking to you, you know that you've got to get your hearing tested, and think of the social engagement. And surely as an older adult, you want your child eating healthy, or the child that you may be teaching to read. So think of what you could be doing with healthier eating, and watching your blood pressure and seeing your doctor on a regular basis. These are things that already can work. So we don't have to say it's ideal and unattainable. It's absolutely within our grasp.
That is such a great point. Some of the most ideal things are happening. We know them. We just have to make them bigger.
Sarah, I'll throw in one of my favorite quotes these days. It's a guy named Hans Rosling, who died in 2017, described as a celebrity statistician. And the quote is, "I'm not an optimist, but I'm a very serious possibilist." And I think that the Lancet Commission talks about what can be done. It's not a bridge too far. It's a bridge that we have all the materials to build, and we just need to build it. Possibilism may be a stronger word than optimism. Let's just get done what we know can get done.
I love that.
That's great.
Yes, please, Dr. Nowinski.
I'll drop one more thing. I want to reiterate the idea of communication and this idea of educating people on what we know today, which is, is happening in real time. But I mean, I grew up in a world where, even my age, my 40s, people are worried about heart attacks. But people don't realize how empowered they are to control their own fate for strokes and dementia and those sorts of things. And it needs to become part of our conversation. We need to let people know how much they still control, no matter what happened to them when they were younger. And then I think maybe one thing that we're lacking that we have for the heart is that, I go in and get EKGs, and there's something to look at. We don't really have those biomarkers for measuring your brain health directly. We have different things for different diseases. But if we had something where we could show people where you stand, I think it would help with compliance. And so I think we need to advance the medicine a little further on that.
Great point. How do you all think that a comprehensive multi-sector approach is something that'll help here? Why is coming together like this matter?
All things that have worked are multi-sector, multi-factor approaches. When I think about when I say things that work, I'm a public health guy, so that's my lens. I would say reduced tobacco use in this country is a huge success story. And it was things at every level, education, laws, smoke-free laws, think air pollution-free laws, et cetera, and so on. Interventions in the workplace, interventions that are targeted at different age groups. And I think my sense is that all tough issues have been resolved, not with a magic bullet, but with a collaborative, team-based approach that brought multiple sectors, multiple perspectives, all working together to get us to where we needed to get.
And if I could add to that, we talk about, the health plans of public health officials, we talk about the sports education, but there's one stakeholder we haven't talked as much about. We've alluded to it when we say communication, but think about media and the marketing. So to me, it is really fascinating that when you look at old folks, and all we see is decline, right? Old folks are virtually never seen on TV, not in movies. They're not the heroes. They have no dialogue. They're essentially been whitewashed out of reality. And yet, and if you see them at all, they're a joke. So as long as we think of old age as decline and memory loss is inevitable, and there's actually a study to say if you watch 4 hours more of television and media, you are more likely to internalize that old age is about decline and memory loss. So if we can work with media and marketing to show the positive effects of aging, and if you have a positive view of aging, you live 7.5 years longer, just for example, that gives people a reason to, oh, I guess maybe I won't eat Doritos day in and day out because I have something to look forward to. And I will have, my kids, grandchildren that I can volunteer, I can participate in sports. If we can begin to change, then there is hope and we can all participate in this as a team sport together.
I'm glad you brought that up, and I can tell you that at Prevention, we will do our part to answer what your call just now, to make aging something that is something you look forward to. It's a good part of life. So thank you. We are on it. Okay, so before we go to our Q&A with the audience, which is we'll do in just a couple minutes, I have one last question that I hope each of you can answer. If you will all tell us one thing that would get us to a better place, one thing that exists now, one thing a policy you want to see, just leave us with more of that sense of hope and possibility today that you've all talked about. Dr. Livingston, would you start us off with that? One thing.
Yeah, one thing. Well, I think people do what they think everyone else does. We know it, like hotels now say, they say with the towels, most people will reuse their towels. Please reuse them or leave them in the bath if you won't. And then people reuse them. Let's get the message out there that people, all of us are working together as a society to prevent dementia. There's a lot we can do. We're doing it really well and we can do it much better in the future.
Thank you. Dr. Nowinski, your turn.
I'll keep it simple. Don't hit kids in the head. That's my one piece of advice to take home.
Thank you. Great. Don't hit kids in the head. We can remember that. Dr. Sanchez?
I'll channel my mother, 86, my mother-in-law, 83. Reach out and touch somebody who maybe doesn't have the same level of social contact that the rest of us may have every single day.
Great. Thank you. We can all do that. And Dr. Ye?
I'll just add in, get your hearing tested.
Thank you.
Easy.
Yes. Great. Those are all really doable things for all of us. Thank you. I have loved hearing your answers to my questions. And now I am really excited to bring you some questions that our audience is asking. So let's start with, how much impact does family medical history have on one's probability of contracting Alzheimer's? We haven't touched on that specifically. Could one of you weigh in on that?
Can I? Yeah. So Alzheimer's is quite common in older age. So family medical history of Alzheimer's might just mean your family lived till they're very old. And if you don't have it, it might mean your family don't live as long. But in terms of genes, the effect of the common gene, which is related to Alzheimer's, ApoE4, is 7%. So if you look at that against the 40% with these reversible risk factors that I've spoken about, it's got a relatively low effect. And even if you have these genes, then then tackling the risk factors mean you're still much less likely to get it. And if you get it, you're likely to get it later.
Yeah, I'm just going to jump in and say that's such an important message, that even with the genetic predisposition, addressing the 12 risk factors will lower your risk. So you can, you do have your own fate in your hands to some degree.
Great, thank you for that message. Yes. I have two questions here that sort of go hand in hand. One is, how can health providers play a part? Primary care doctors, what should they be doing? And then at the next level up, you know, our health system and Medicare, what can they do to address the risk factors? So that's a big question, and I know we've touched on it in, you know, some ways, but let's focus on it here. Who would like to jump in first, either on doctors or you know, health insurance and Medicare?
So I can weigh in on a couple of those points. So, you know, as a physician or as a primary care physician, it'd be good to know that 6 in 10 older adults actually worry about their brain health. It's their #1 worry in wellness. So if you know that that is something people worry about, bring it up in your conversations. And when you talk about it, you can then start having this message. There are things you can do. You know, the stopping smoking, the alcohol, don't get hit in the head, you know. These are all conversations because prevention is such a key part of our medical care. Secondly, for Medicare, I'm thrilled that they've included, you know, doing cognitive assessments as part of the Medicare exam. But I do think we need to change this notion that age-related decline, hearing loss decline are all normal consequences of aging, because as long as Medicare acknowledges it and doesn't reverse that thinking, then of course nobody begins to pay attention, and that's why we get silent epidemics like hearing loss. So I do think putting in those policies into place, identifying these risk factors, and maybe creating the kind of value projects, innovative programs in place addressing these risk factors. And then you've got NIH funding, you know, and CDC tracking that could also collectively becomes that multi-stakeholder engagement.
I'm going to jump in and say 6 of the 12 risk factors have a strong evidence base for doing the clinical preventive service in primary care settings. Hypertension, diabetes screening, obesity screening, smoking screening and counseling, depression screening, alcohol misuse screening. I guarantee you, the data would say there's more room for improvement than there is room for doing worse. So there's opportunity to say these are things that we should say should be occurring 95% of the time in patients. That's the one side. So clinicians need to be held accountable and hold themselves accountable to delivering these clinical preventive services that make a difference. Health systems need to set things up in ways that incentivize and reward physicians for doing so. It's a triple bottom line. Patients are healthier, the system saves money, and the doctor gets rewarded for doing the right thing. Four, because the health plan itself reaps some reward for saving that money. So there's promise, but we got to hold ourselves, and we have to hold our feet to the fire to deliver not anything new. These are already evidence-based interventions that make a difference. Now let's go out and make sure that they're being delivered.
Can I
just add in hearing loss, which is, you know, not part of that set of preventive services. And I like the fact that loneliness, social connection are now questions that we can ask about, and we recognize their impact on health. So there is, if you just took these 12 factors and built that into the preventive services, but health plans cover, that are important to the physicians, and we know they're important to the consumer.
Dr. Livingston, did you have something else to add?
Yeah, I was going to say that in England, we now have, as part of a midlife check, which is mainly done by nurses rather than doctors, is people are given a personalised risk for dementia. They say, we know that dementia is something that people worry about more than anything else. And for you particularly, you have a high, they don't look at all of them yet, but hopefully they will soon. You have a high risk of, you've got hypertension, or you have diabetes or a risk of it, you're obese, all of these things, and you with the sort of the 6 factors that Eduardo talked about, these give you personally a risk, and this is a plan for you personally to tackle it and reduce your chance. And I think that is excellent. We've a new paper that came out this afternoon in Lancet Healthy Longevity, which looks at the cost and the amount of cost saving in treating some of these, including hearing loss. And it's calculated for the UK, but a lot of money would be saved, and we're now campaigning for them to begin to put this in all over the country, stop it for every person, stopping smoking, tackling hearing loss, and tackling high blood pressure. And I think that we have to have, we have to campaign so that it becomes part of the Medicaid or the NHS or whatever system that we're part of.
You know, Dr. Nowinski, could I call on you for this too? I'm curious where you think doctors fit in when it comes to kids and sports and not hitting them in the head. Like, is this mostly a parent situation, or do you think there is a role for the medical community?
So that's a very interesting question. It's been studied quite a bit. Doctors mostly don't want to get involved in that discussion. So what's interesting is that almost all pediatricians wouldn't let their child play tackle football before high school. But that's not necessarily what they're going to tell the parents. And part of that is maybe the evidence isn't strong enough for them to make a choice. Part of that is, maybe you're going to lose patients. Because you say no, you can definitely find a doctor who's going to say yes. And so it is. I think we look at it as our job to strengthen the evidence so that doctors feel more comfortable making those decisions.
Great point. Dr. Ye, I think this might be a question. Well, actually, I think anyone can answer this, but somebody wanted to know about changing their family members' thinking about cognitive decline being a part of aging. The question asker specifically said, in some Hispanic family members believe that it's, always going to happen. And there may be other communities that feel the same way. I know in my community, it's the same. So what would you say about changing this thinking? Like in that immediate, how do you talk to your parent or grandparent about it? Sorry, go ahead.
Yeah. So I know it's very difficult, especially if it's been culturally built into you and if the media around you reinforces that kind of culture, but it's not inevitable. So for example, we could send people, there's an ARP website where they hired photographers to go all over the world to look at older adults enjoying life. So there are gauchos in Chile. There is a grandmother in Iraq who's adopted 22 orphans. There are microeconomic grant deliverers, who do grants in local communities for building entrepreneurs. There are dance classes in Chongqing, China. There are gardeners and farmers. So I think if we can start to show examples that it is not inevitable, because there are people all over the world who are living with vibrancy and vitality. There's a study out there looking at health limitations on work and daily living. And sure enough, in your 50s, 90% have no limitations. But how many people knew, and what's in the study, 56%, over half of 85 and older say, I have no limitations because of health on my work or daily activities. So we need to showcase and demonstrate that it's not inevitable, because right now, the way the media portrays, it's just a joke and it's all about decline. So it can be done, and maybe examples within their own neighborhood or community that they're not exceptions, that they could be the norm, and it's easy and it's doable.
Thank you. We have a question about diet and nutrition. It's specifically, how was diet considered by Lancet? And what role does nutrition play? Dr. Livingston, can you jump in on that?
Yeah, I think that diet is complicated, and because the whole diets are very complicated and they last, by definition, your whole life, it's quite difficult to work out the exact role. But looking at long-term studies, people who have a sort of Mediterranean diet are less likely to develop dementia, and similarly with a sort of Finnish Norwegian diet, they're less likely to develop dementia. What we also know is that taking vitamins and supplements appears to do no good whatsoever. So it's much more your whole diet that makes a difference. And these selling them in shops to help you ward off dementia is not going to work. But eating a healthy diet at the very least makes you less likely to be to have high blood pressure and to be obese, and may by itself also contribute to a reduction in dementia.
Thank you.
I'll just add that if you look at leading causes of death and disability internationally, broadly, not just dementia, a poor diet is at the top or very near the top of that list. But I'll reiterate what Jill said, which is it's hard to tease it all out, except there is no doubt that obesity, type 2 diabetes, and high blood pressure are downstream from eating too much of the stuff you should not eat too much of. That's the best way to put it, so that you don't talk about good food and bad food. But that's how I think diet plays a role. And again, there's the collateral benefit in the other direction, the degree to which you can avoid heart disease and stroke by eating a Mediterranean diet. I think everyone on our panel would say that's the degree to which that is going to contribute to reducing the likelihood of dementia.
Thank you. I think we have time for just about one more question. And we actually have a couple of people who've asked along the similar lines of, how can organizations that work on some of these common risk factors, work together? How can we, why does having this national goal, how can that drive us to actually doing the work of working together? So what can you leave us with, each of you, or, whoever can weigh in on, what's the next step for us in working together?
Well, I'll just jump in and say I work for the American Heart Association. Here I am. So I'm speaking on behalf of AHA. We will pull our sleeves up and work with any organization that has a common goal with us. And that common goal would be optimizing the health of all Americans. I'll share our mission statement, not something I ordinarily do, except our mission statement is to be a relentless force for a world of longer, healthier lives, period. We have license to be at the table with anybody. And I will say, in this time of COVID, when we're on the other side, whether it's in Europe or in the United States, I think there's going to be a reckoning and an opportunity to rethink what health and healthcare look like. And all of us need to invite ourselves to those discussions and say, this is what we expect a health system to be, not just from a communicable disease perspective, but from a non-communicable disease perspective. So I'm ready. Invite, we'll be there.
Yeah. And I just want to say, ARP is already there. We worked with you in putting out the report in February about the global health connection and cardiovascular risk. So we are there to partner. ARP, 5 years ago, started the Global Brain Health Council to bring together the experts across the country, across the world, not just in this country, to bring together the experts on global health to make sure we have the science and the stakeholders. We are obviously working actively to change that perception of aging. We even got Allure magazine to actually ban the word anti-aging from all of its ads and advertising, because why are we anti-aging? Think about that question of how do I convince my my older parents that it's not inevitable, and can we just learn to say, not that you look good for your age, but you just look good.
Great point. You are all leaving me feeling very optimistic about this national goal, that it is doable, because we are all here. We have this multi-sectored approach. And so everyone who is out there, I think, use this as a jumping off opportunity to reach out to the other people who are here and work with them to, to make a difference in your communities and with each other. With that, I would like to say thank you to all our panelists and to everyone who joined us. And I wish everyone well as you go forward in preventing dementia and doing all the hard work that you all do.
Thank you.
Thank you.
Thank you.